Okay. So good evening and welcome all to the 72nd chapter of IASO Masterclass. I now invite IASO President Dr. T.S. Ross sir to deliver the welcome address.
Good evening and welcome to the chapter 72 of the IASO Masterclass. It will be on oral cancer. We have an excellent faculty. CS Mani is a senior surgical oncologist with a special interest in head and neck cancer. Right now he's working in Apollo Specialty Hospital, Chennai, a very well-known academician. We also have Dr. Shekhar Gupta, another senior surgeon and an active office bearer of the IASO and a leader. He is currently the director of cancer surgery, Apollo Cancer Center, Kolkata. He'll be the examiner. We have a young and energetic Abhay Katepur, consultant in surgical oncology, Sri Shankara Cancer Hospital and Research Institute, Bangalore, who has created the case capsules, and he would be moderating the session. Thank you. Thank you, Ziba. I request Ziba to run the show.
Thank you, sir. So there are two candidates with us today, Dr. Densi Hansalia from BHU and Dr. Siddharth Songatkar from GCRI. Just basic housekeeping points, instructions for the candidates. Kindly answer to the point, and you're not expected to know all the answers. There's no harm in mentioning. If you do not know the answer, it will save time and it will maintain the flow. Examiners are always giving some hints all the time, so keep an open mind. I request the examiners, in the interest of online viewers, please give expected answers to the questions that are unanswered or answered incorrectly. And whenever you are asking a question, please direct the question to each of the candidates by name so that each of them get equal opportunity. And the rest of the participants, I encourage you to participate actively in the chat box and in the Q&A section, and we will try our best to answer your questions during the discussion and even after we are done with the discussions. Now, I welcome Dr. Abhay to start the moderation for the oral cancer masterclass. Over to you, Dr. Abhay. You need to unmute yourself.
Yeah, good evening.
Good evening, sir. Yeah.
So I hope the slides are seen.
Yes.
We'll start off with the first case. He's a 45-year-old gentleman, diabetic, tobacco chewer and alcoholic, who presented with a non-healing ulcer on the left lateral border of the tongue since the last 3 months. On clinical examination, the patient had no trismus. There was some tobacco staining of the teeth, and an ulceroproliferative growth is noted on the left lateral border of the tongue, which is not involving the base of tongue or the tip. It does not cross the midline. It abuts the floor of the mouth. There's no ankylosglossia. It is very well away from the mandible, and cervical examination shows no palpable lymph nodes. So how would you work up this patient?
Abhay,
We
sir,
have two examiners,
yeah, let's ask the candidates
we
with
have two
name.
examiners, Dr. Densi and Dr. Siddharth, right?
Yes, sir. Welcome,
Yes, sir.
sir.
Good evening, sir.
Good evening.
Good evening. Good evening.
So Dr. Densi and Dr. Siddharth are the final year students of MCH. So can you please direct the questions to them by name? Thank you.
So Dr. Densi, what's your first impression on seeing this patient? What are the points you will examine in the clinical examination, although it's more or less given in the slide?
What is
Can
missing?
you please enumerate?
Yes, sir. Sir, I would like to examine digital examination. On digital examination, I would like to see the extension of the lesion as well as the underlying induration and whether the floor of mouth is involved or not, which they have mentioned that the lesion is abutting the floor of the mouth. Also, I'll examine whether it is the posterior extent of the lesion, the palpation of the cervical lymph nodes.
What about the rest of the mucosa of the oral cavity? Would you note something about
Yes,
that?
I'll examine the rest of the mucosa of the oral cavity for any synchronous lesions or any other non-malignant lesions which are present for submucous fibrosis.
Okay. Anything you want to add, Dr. Siddharth, on this?
Dr. Siddharth, do you think
Yes.
there is something important missing in this list of findings that has been presented to you? So we need to clinically stage, and
Yes,
for the clinical staging, what is missing here? Okay, Dr. Densi, you want to take it?
So in clinical staging, the depth of invasion we need to find out.
the size
Yeah.
of the lesion also.
Yeah.
Hmm.
So dimensions, both the width, the length, and the depth is missing here, which is very crucial, don't you think so?
Yes, sir.
Yes, sir.
So prior to doing a workup, we have got to do that clinical staging. And you're right when you pointed out you want to digitally examine to find out the extent of induration around. And with that same length, you should also have mentioned you would make an assessment, digital assessment of the depth of invasion. That would have given us a clean answer for proper staging.
Yes, sir.
Yes.
Okay. We can proceed.
So, what would be the workup of this patient in these lines?
Who wants to take this question? Dr. Densi?
Yeah.
Sir, I will do punch biopsy for this patient. For the imaging, I would like to do MRI tongue plus neck.
Contrast or non-contrast?
Contrast, sir.
Okay. Anything else in the imaging?
Sir, nothing else so far, sir.
Okay, you would only image the head and neck area?
Sir, for metastatic workup, I would like to image the chest. I would like to do contrast and CT scan of the thorax.
Okay. Dr. Siddharth, any role of PET-CT?
As per the examination findings, sir, this appears to be early lesion, and there are also no neck nodes involvement. So I would not like to go for a front PET-CT in this patient because I am not suspecting any metastatic disease, particularly in this case, sir.
Okay, you're correct. So considering this an early tongue, an MRI and a CT chest, even a non-contrast CT chest suffices as imaging investigations. And Dr. Siddharth, what are the points you would look for in the MRI? What are things you would discuss with the radiologist?
In MRI, I would first discuss about the depth of invasion, which we can calculate roughly based on the tumor size. And if the tumor is reaching up to midline or extension to floor of mouth or base of tongue.
Okay. And then carry on. Invasion of any structures, any muscles. If it was a little bigger. This is a very early disease which is showing, Dr. Abhay. If it was a little bigger, what are the other points you would want to know?
Involvement of any.
Yes, Dr. Densi.
I would like to know the extrinsic muscle of tongue involvement as well as the floor of mouth muscle involvement.
What is the floor of mouth muscle, doc? Which muscle are you referring to?
Sir, that will go to genioglossus and mylohyoid, which is way too far for this lesion. But sir said as that if it is a bigger lesion, then we would consider identifying such muscle involvement.
Right. So, what involvement in this case would make it unresectable?
Sir, as this is a ulcer involving the lateral border of tongue, if this would be involving base of tongue reaching up to vallecula, then it will be unresectable. If it is going and involving floor of mouth and going down to the neck and skin involvement, then it can be unresectable. Then extensive involvement that making the resection is functionally morbid, it will be unresectable.
Okay. So when you have a clinical finding of no ankylosing, are any of these facts tenable in this case?
No, sir.
Yeah. So is there a situation where you would, instead of MRI, also look at CT scan? And what are the problems with CT scan in any case?
Sir, if I am suspecting involvement, bony erosion or involvement, I would like to go for CT scan. But the CT scan will not show the soft tissue involvement, neurovascular involvement, and the margin for the resection. So in this case, I would go for MRI, sir.
Dr. Dempsey, is there any special situation you will choose an CT scan or MRI for a tongue lesion?
I think he has covered, sir. I was going to answer about the bony involvement, sir.
Yeah, bony is fine, but is there any situation other than bony involvement you would still think about a CT scan? So let's argue that you have a very, very thin lesion, okay? It is just barely erythroplakia, or maybe there is invasion there. We are not sure. So if you have such a case, would you still do an MRI?
No, sir. I would not, for thinner lesions, I would not get MRI based
Why?
on clinical.
Why? Why would you not get MRI for thinner lesions? Dr. Dempsey?
No, sir, I would not take this question, sir.
You didn't get the question, or you don't know the answer?
I don't know the answer, sir.
Okay, all right. So there are situations, Dr. Siddharth is right, when it's extremely thin, we don't want to do an MRI because what is the duration it takes to do an MRI of the tongue? What duration?
Yes, sir.
How long do you think the patient is going to be inside the machine?
Yes, sir. The patient is approximately 15 to 20 minutes inside the machine, sir.
Siddharth, any other answer?
Sir, approximately it takes 30 to 40 minutes.
Okay, all right. So how long does it take in a CT scan machine?
Hardly, sir, 5 to 7 minutes in and out.
Okay.
Yes, sir.
So how does thin lesion make it difficult for the MRI then?
Okay,
So
because of the patient will move.
Not the patient, the tongue.
Artifacts.
Tongue.
Yeah, the tongue will move.
Correct. The tongue is impossible to keep the tongue in a fixed position for that length of the time. And so, you'll have a lot of swallowing times and, breathing kind of times. So this is going to make your delineation of the thin lesions on an MRI extremely difficult. In such cases, you'd rather go with a CT with contrast that can delineate a thinner lesion better.
Okay.
Yes, sir. Yes, sir.
Okay. Go ahead.
So would you want to do an EUA for this patient? Examination under anesthesia.
No, sir. I would not go for UA since I can based on the imaging, based on the clinical picture, I can very well examine the BOT and floor of mouth easily. So I would not go for EUA. But if the lesion is slightly bigger and patient has significant pain, then I would like to go for EUA because patient would not tolerate clinical examination.
Dr. Dempsey?
But the trismus is restricting my, if the trismus is restricting my examination of the posterior extent, then I would like to go for EUA.
Or if you have an extremely apprehensive patient who is not lending himself for a clean examination, in spite of your reassurance, okay, which can happen in certain odd cases, not the regular day. But, there are people who won't let you with the, very severe gag reflex or apprehension, tensing their tongue where you can't really make out, due to the pain and all that. Of course, you should try with a local anesthetic examination before you can go to that extreme of UA.
Yeah.
So this patient, we did a biopsy. It has come as a well-differentiated squamous cell carcinoma. And we have done a contrast-enhanced MRI for the local staging and a CT thorax for the imaging of the lung. And these are the images.
So, Dr. Dempsey, would you like to argue with your pathologist about the report? You're not too happy with the report. Are you happy or not happy?
The pathologist have mentioned only the differentiation. He or she has not mentioned the neurovascular invasion, which could have been mentioned in the report, sir.
With a punch biopsy? I'd be afraid to ask that they'll slap me.
If it is a bigger punch.
Bigger punch. How big a punch can you take it inside the mouth? Yeah, well, that's not the right answer. We're not looking for neurovascular bundle. Dr. Siddharth, what is your take on this?
I don't know, sir. This.
Okay. All right. So I'm way more concerned about the differentiation aspect. See, in a tongue lesion, predominantly over 70% to 80%, they would call it moderately differentiated because they'll sit on the wall. They'd not stick their neck out and call it either well differentiated or the poorly differentiated. So that kind of gets my antenna up. And also in the tongue. So if it was on the buccal mucosa, and then you go back to your clinical history, see what is the duration? What is the duration of lesion in this patient?
3 months.
3 months. So we are, kind of looking at the image. Okay, let's look at the image. And now, do you want to stage the disease? Because we didn't have the dimensions earlier. But can you look at this image and want to take a call on the staging?
Based on these findings, the tumor is appearing less than 4 centimeter. And in its clinical examination, there are no neck nodes. So my clinical staging would be CET2 and 0.
What are the other things you're looking at in this MRI, which are very important from the resection point of view?
Sir, we'll look for the depth of invasion. We'll look for the base of tongue area. There's a posterior part of the tongue area, and we'll also look for the floor of mouth area, which will help me to decide the resection.
Yeah, so here you can see that it's well away from the midline. It's not going on to the base of the tongue. And in the other sections, you'll be able to see the sublingual spread. Although this is a very small lesion, in larger lesions, those are the important points you want to cover, see in the MRI.
Dr. Abhay, do you want to highlight to us where the...
Yes, so this is the tumor is in the second image. You can see the whitish area. That's the tumor. Yeah. But in the third image, you should see the lymph nodes. See, the lymph nodes are also there. Here is submental. Okay. Can you see?
Yeah.
So actually, even in an apparently early tongue, you can get lymph nodes. So you need to be very careful to assess the lymph nodes correctly. So as rightly told, because it's a very small and a superficial lesion, The pickup on the MRI beyond your clinical examination may not be that accurate. So you need to be very careful when you're reading these MRI. I'll just share the report. So the maximum dimension of the lesion was 15 mm and the depth of invasion was around 6 mm. None of the muscles, the genioglossus was not involved. The hyoglossus was focally involved. The neurovascular bundle was free. It was abutting the floor of the mouth. There was no mandibular involvement, and although the lymph nodes seemed enlarged, they have reported it as a multiple reactive lymph nodes. So this is what was the MRI report.
So, Dr. Dempsey, what curiosity will you get? There is a node seen there in the image, and the radiologist is calling this reactive. So, what would be your inquisitiveness now?
Sir, as the lymph node which can be seen in the scan are more of the oval in shape, and that is why probably they are mentioning it as reactive nodes. But as of the tongue lesion is concerned, I would still go ahead and do plan a neck dissection.
That's fine. I mean, that's absolutely given. But here it is DOI, they're calling it as less than 6 millimeter. That is fine. Is there a DOI on which you will not do a neck dissection?
Sir,
Less than 3 mm.
Siddharth, what is your take?
yes, sir. Based on recent studies, less than 3 mm, if DOI is there, we can avoid the neck dissection.
So because because the DOI is here is almost 6, so you will still consider in spite of what the radiologist may think. But also, is there anything else that you want to know? I would like to know what is the duration before or after the biopsy that this MRI was taken. Is there any importance to that? What is the time profile between the biopsy and the MRI? Was it anteceding the biopsy or was it after the biopsy that this MRI was done? What do you think?
Yes, sir. If it is done before the biopsy, then it will alter the architectural appearance of the lesion in the MR and probably the size of the lesion also.
Dr. Siddharth, what would be your preference? Would you do the MRI and do the biopsy, or you will do the biopsy, confirm, and then do the MRI?
I will get for biopsy followed by MRI, sir, because biopsy may alter the dimensions of the tumor as in the early, as in this case, sir. So I would go for biopsy followed by MRI.
Clarify, I didn't get it right. You will do biopsy first or MRI first?
Biopsy first.
What about Dempsey?
I would like to do MRI first.
Okay, Dr. Shekhar, you have to sort them out.
See, there's an obvious lesion, which is obviously malignant. So, as per, when the patient comes to the OPD, we know this is malignant, and we usually do send for the biopsy first, but it does change the MRI artifact. So, we would go for the biopsy first, but we would take that into account when we order the MRI.
So there is the other point of view also, you guys should know that when possible, when clinically malignant, you'd rather document the MRI before you do any biopsy procedure on that, which is also a point that we should note. Okay, so maybe there are two schools of thought, but if it is clinically your diagnosis a malignant lesion, then we would rather document that with an MR and then do the biopsy procedure.
Yeah. So both answers are yes. You can do both.
There are people who would do the biopsy and then send the patient for MRI immediately after, that means they're given a lot of local anesthetic and then taken a punch and then send the patient the same day or the next day for an MRI. And that kind of upstages the disease a lot. Okay, go ahead.
So, what type of treatment would you offer for this patient?
Dr. Dempsey or Dr. Siddharth?
Yes, sir.
What's your treatment plan?
Sir, I would consider. Yes, sir.
Yeah, please go ahead.
For this patient, sir, I would consider surgery. And for surgery, I would go for a wide local excision of the lesion with elective neck dissection in the form of supraomoid neck dissection.
Okay, this person is going to step into the shoes of Asha Bonesley now. So what do you like to do, Dancy?
Sir, I would like to take up for surgery, not radiotherapy.
Good. You're very confident. Very good. It doesn't matter if you want to destroy his singing career, but we need to get this cured, isn't it? What do you say?
Okay, now I got the question, sir, about that Asha Bhosle thing. Yes, sir, we can definitely go ahead with radiotherapy if the person is of a specific.
No, no, no. You don't change the answer because I'm intimidating you. Okay. So, singing career or not, only if he is able to live a normal life, that comes into the picture. Okay. So,
But sir,
between,
T1 and T. Sorry, sir.
yeah,
Sorry.
correct, correct. You're going to argue that both these situations, you're going to have the same amount of cure.
Yes, sir.
In which
Yes.
case you're right. But in spite of that, in a tongue lesion, it is appropriate to have a surgical staging rather than, blind radiation therapy. And of course, there is a lot to do with rehabilitation and all that. But nevertheless, I think we must be very sure that in the anterior tongue, our chances of getting things straightened out with surgery is far, far superior than doing radiation. And you'll exhaust that modality because he's already a chewer and you see all his teeth are stained with tobacco. So you don't want to, and he's only 40 something guy.
35-year-old, whole life
Yeah.
ahead of him. You
Yeah.
can't take a chance with him.
Yeah.
Yes.
So what are the criteria for you to give RT for these type of lesions? When you should give? What are the indications for RT to the tongue?
If there is a early lesion, T1, T2 lesion, tongue is well mobile, patient is able to move the tongue out of the oral cavity. It should be away from the mandible and not involving floor of mouth. Then I can consider RT for this patient.
So,
And also, I would counsel the patient regarding surgery versus RT and the advantages and disadvantages of the radiation. As sir has mentioned that he's a tobacco chewer, then patient may land up in another malignancy and may need RT in future also. So I would not consider RT and surgery for this patient.
so because this lesion is creeping onto the floor of mouth is a relatively thicker lesion, it's around 6 mm.
Yes,
So
sir.
it's because of these two criteria, probably RT is not a very good modality rather than surgery.
And
Yes.
when you
No.
looked at the outcomes, the quality of his singing or voice, radiation is no less tampering with the voice quality than surgery as well. Remember, just because you are giving radiation does not mean his voice quality is going to be the same as before the treatment. Okay, it's already altered by the fact there is a cancer developing in one lateral border. And going ahead and doing a radiotherapy there is not as if it is going to bring back that voice quality, but it can worsen it. Why? Why will it worsen it?
Because it will call surrounding tissue inflammation and followed by fibrosis later on.
Do you think fibrosis is the reason? Dr. Siddharth, do you think anything else would be the reason for a loss of voice quality?
No, sir, I'm not sure.
What is the commonest side effects of radiotherapy?
Xerostomia, sir.
And what happens when you have to the voice when you have xerostomia?
Yeah, the quality changes. Yes.
Have you not seen people who have to take a sip of water every 5
Yes.
minutes, every 10 minutes, they need to talk? And their voice would become very strained and labored. It's not going to be the singing quality of voice. So that is no substitute for a profession, occupation like that as well. Okay.
Yes.
So we need to
Yes.
highlight these things to the patients and helping them to make the choice.
Yes, sir.
So we agreed on surgery. What surgery?
I will do wide local excision with primary closure of the area, as well as neck dissection, selective lymph node dissection.
What levels would you cover in selective lymph node dissection in this case?
So in this case, I'll cover level 1A, 1B, 2A, 2B, and 3.
Okay. You would stop at 3.
Yes, sir.
Okay. You have any points on that, Dr. Mani?
Dr. Siddharth, do you have a changed opinion? You stick to Dempsey's line of thought.
Yes, sir. Although there are chances of skip metastasis to level 4, but there are almost very low, around 4 to 5% chances to level 4 lymph node and mets. And also, sir, in these cases, the lymph nodes doesn't appear to be involved. So I would still go for level 1, 2, and 3 neck node dissections.
I'm going to argue that I will stick to a sentinel node biopsy. What do you guys think?
We can go for sentinel lymph node biopsy, but the procedure for it is very cumbersome, sir, and costly, and also patient would require 2 procedures. So
Two procedures? Why 2 procedures, doc? Why 2 procedures? Dr. Dempsey, do you think it's a staged procedure when you do a sentinel node biopsy?
Sir, sentinel lymph node biopsy can be done, but there is no proven superiority as of now. Also,
There's no
sir,
inferiority
there
either,
is,
right?
yeah,
There's
no
no
inferiority.
equivalent. Yes.
And
No, but will it require 2 procedures or 1 procedure?
sir, it will require 1 procedure, but if in final histopathology, if the lymph nodes come out to be positive and we have not staged the neck appropriately, then we might need elective therapeutic lymph node dissection later on.
Then how will it be non-inferior? If a sentinel lymph node biopsy would miss lesions like this, how would you call it a non-inferior? It is inferior, if that is the argument.
Yeah.
You get my point?
Yes, sir.
Yes, sir.
Yeah. So if you argue it is non-inferior, then you must also understand that it is as good as doing a proper neck dissection where you pick up the right node in any case. So in the trial that Tata Memorial did about elective node dissection, okay?
Yes.
Yes.
What is the occult node positivity in tongue?
Sir, occult node positivity was 13 to 15%, if I'm not wrong.
Okay. I mean, I also don't know the exact number, but I'll agree with that range.
It was 13%, I think. Yeah, there was an occult node positivity on final histopathology.
Yes,
Yeah.
sir.
Not on, So,
Okay.
yeah.
So, they're the ones also who suggested about the DOI correlation with the occult node, isn't it? So we need to know that correlation quite clearly. And here we have a 6 millimeters. So you will definitely have to address the neck. But, you have no choice about observation of the neck in this case. But the way you address is now, if you're going to be modern in outlook or updated in your subject, you must equally weigh the sentinel node biopsy as an option.
Yes.
Okay. So there's something about margins here.
So
At
what's
least
your
5 millimeter.
primary in this case would be a wide excision glossectomy, as you said, Dr. Siddharth?
Yes, sir. Sorry, sir.
What are your margins on table?
I would take, sir, 1 centimeter margins.
Okay.
Betsy?
So grossly 1 centimeter margin so that I can predict at least a 5 mm pathological margin.
Okay. So you expect 50% shrinkage after you remove.
Yes.
20 to 30% shrinkage.
On table, sir, it shrinks to 20 to 30%. Then if it is fixed to formalin, then further 10 to 20% it will shrink. So approximately, sir, on table, if you have taken 1 centimeter margin, then maybe it come as a 5 mm margin, sir, on final histopathology.
It should be at least 1 centimeter margin. That is the answer.
Yes.
So do you think you can measure this in the depth, 1 centimeter? I mean, you can mark it with a scale on the mucosal surface, but how will you mark it on the depth?
Sir, we cannot mark it as such, but we have to
Do
palpate
you
the
want to
area beyond it.
do you want to get an intraoperative help?
Yes, sir. If available, I can get frozen section.
Frozen section, if available. I mean, I'm saying about intraoperative guidance for your deep margin, not as in when you are resect and then send it.
Okay, sir.
What do you go on doing while you're resecting the base?
So I would like to do palpation, digital guided
and 3-dimensional
fixation of the lesion.
Yeah, always keep the 3-dimensional aspect in mind.
Yes.
And keep on palpating, because you can figure out that 1 centimeter thing quite easily with experience as you keep on resecting the base.
Yes.
What about frozen section? If
I would not like to rely on a frozen section.
If you don't have it, there is no option. But if you do have it,
I would not like to rely on it. But if in case I have a query, then only it might be as a supportive investigation.
is gross inspection of the specimen by the surgeon on table way inferior than a frozen section regarding margins?
No, sir.
Yes, it is almost as good. Do revised margin. Suppose you come at a 2 millimeter margin on frozen section. Is that desirable, or an adequate margin is the first thing desirable?
No, sir. Adequate margin on the first resection is always desirable. That there is no role if you have taken extra margin afterwards.
Yeah, it does not help. And what's your plan for primary closure? Is there a plan?
Yes, sir.
Yes, sir. Yes, sir.
Okay, so this is a 1.5 centimeter tumor. Suppose this was a 2.5 centimeter tumor and the patient is a teacher.
Sir, still I would like to go for primary closure if it is not involving the floor of mouth excessively.
That is Siddharth. For a 2.5 centimeter tumor with adequate margins, you would land up with a 4 centimeter defect anteroposteriorly. Primary for a teacher?
On table, sir, I will decide if the defect is less than 1/3 of the total tongue, and then I will go for primary closure. And if it is more than that, then I will consider other reconstruction options, sir, in case of free flaps.
Which would be the best flap? I mean, what are the reconstruction options?
Best for this defect would be radial artery foramen flap, sir.
Do you agree with that, Dr. Dempsey?
Yes, sir. If the expertise is available, we can go ahead with the radial artery foramen flap. If the area is to be reconstructed, the better one is that option.
And if this tongue lesion is encroaching on the mandible, anything else you want to add to the dissection? Alveolus? Larger than this.
Did not get the question, sir. Sorry, sir.
If the floor of mouth was involved and going on to the alveolus, you wouldn't get a margin.
Yes, so for the margin, I would like to go ahead with marginal mandibulectomy for such a patient.
Is that same thing?
The tongue lesion involving floor of mouth and mandible, I would go for compartmental dissection within tongue, extrinsic muscles, floor involving the involved portion of mandible along with the neck node, sir, 1A, 1B.
Usually a marginal mandibulectomy suffices, but your MRI comes in useful there to estimate the depth at which you have to resect the level of your marginal mandible. Dr. Mani, you want to ask anything more on this?
Mani sir is having some technical issues, sir. So
Okay.
we'll be logging out and logging back in sometime.
Okay, fine. So I think we have covered this part, and I think time is a constraint. We can go on to the.
So for this patient, we did a partial glossectomy with a supraomoid neck dissection and a primary closure. This is the histopathology report. It was a 2.5 centimeter tumor, moderately differentiated tumor with an 8 mm depth of invasion, with the worst pattern of invasion being 5. There was no LVI or PNI, nodes were negative, and our margins were free.
Okay. Closest margin, do we have any information on closest margin?
Closest margin was more than 6 mm. 6
Are you
mm.
happy with the histopathology report, Dr. Siddharth? Is there anything else you want to know?
No, sir.
You happy with the pathologist, Dancy?
Yes, sir.
You're happy, right? Yeah. So this was a pretty comprehensive report. And what would be your plan now for adjuvant? I think we can go on.
As sir, in this histopathological report, the lesion is early. There is only one high-risk feature, which is in the form of WPI of 5, sir. And so I would not consider adjuvant treatment for this patient in the form of radiation, sir.
Dr. Dancy?
Check your depths.
Sir, I will consider adjuvant radiation for.
Why? Which factor?
Sir, the worst pattern of invasion is 5. Also, the depth of invasion is 8 mm, so it makes it T3 lesion.
Yes.
So I would go ahead with radiation.
Yes. So depth is the part here, along with the worst pattern. Depth is an absolute indication. Yeah. So carry on, Dr. Verma. I think we should press for time.
So can we go to the next case?
So did we give adjuvant radiation for this patient?
Yeah, this patient is currently receiving adjuvant radiation.
Okay, and coming to follow-up protocol, the patient completes adjuvant radiation. If the radiation oncologist is done with him, when would you want to see the patient back in your OPD?
I would want to see the patient back after 2 to 3 weeks of completion of the radiotherapy.
Okay, Dr. Siddharth, what's your follow-up protocol?
After radiation, we follow up after 1 month to look for any radiation-induced symptoms. And for the follow-up of the patient, we ask the patient to follow up for first year 3 monthly, then second year, from second year 6 monthly, sir. And after that, 8 monthly follow-up, 6 to 8 monthly, sir.
Dr. Dancy, would you want to change the follow-up protocol?
Sir, in the first year, I would like to follow up the patient 3 monthly, and from the second year onwards till the 5 years, I'd like to go ahead with the 6 monthly follow-up.
Both answers are correct. Some people would want to follow up 3 monthly for the first 2 years, and then go on to 6 monthly for the next 3 years. That's more of a routine thing done in actual clinical practice. We can go ahead with the next slide, Dr. Abbas.
So this is the case number 2, 56-year-old lady, hypertensive, chronic arachnic and tobacco chewer, presented with a non-healing ulcer near the right lower alveolus of 1 month duration, associated with loosening of teeth. Clinically, there was no trismus. Again, nicotic staining was noted. There were multiple caries teeth. And you can see a 3 into 3 centimeter UPG in the right lower alveolus at the level of the last molar tooth, which was involving the RMT and the lower GBS. The overlying skin was free. The upper GBS was also free. There was no other abnormality noted in the oral cavity. And a palpable right level 1D lymph node was found.
Okay. Next slide. We can go on to the next slide. Are you happy with this findings? Do you want to add anything else? Any of you?
No, sir.
The dimensions are mentioned here, unlike in the previous case. Okay.
Yes.
Yeah. So that's very important. Next slide.
So how would you evaluate this patient and work up.
Again, would you image first or biopsy first?
Sir, I can go ahead with biopsy followed
Biopsy.
by imaging.
Yeah, that is usually the done thing. Although, as in the
Yes.
previous case, the biopsy does lead to a little bit of artifact, but that's very minor.
Yes.
Imaging.
Sir, imaging, I would like to do
Yes,
the contrast enhanced CT scan from the skull base to the clavicle and from with 3D reconstruction of the bone, and along with that CCT thorax
Okay.
for metastatic workup.
Dr. Siddharth?
Yes, sir. I would
Why
like
would
to
you,
also
why
go.
would you do a CT in this case and not an MRI?
Sorry, sir.
Why a CT and not an MRI, unlike in the previous case?
Yes, sir. Since on basis of the history, this patient has loosening of teeth. On examination, there is a disease involvement in the GBS and appears to be significant paramandibular disease. So I'm suspecting a bone involvement in this case, sir. So I would go for CCT, sir, with bony 3D reconstructions.
Okay. Very good. So dental evaluation. Any other suppose your 3D recon you're not happy with. Any other investigations you would want to add to this patient to understand the extent of bony involvement? You don't have a 3D recon or you're not happy with the 3D recon, your radiologist can't provide you with one.
Although, sir, I would, although historic, I would ask for the OPG, sir, orthopantomogram. That will also help me to assess the overall the health of the teeth. So I can go for dental evaluation also in the same investigation before commencing on any treatment, sir.
Yeah. OPG would be sometimes comes in handy when you don't have a 3D recon, or sometimes a 3D recon doesn't give the definition of the inner table. Your radiologist does not give you the full 360-degree circular picture, then OPG is also an adjunct tool to understand the extent of bony involvement. Yeah, we can go on to the next one.
So the biopsy was a moderately differentiated squamous cell carcinoma. We have done a CECT for the local imaging, and a CT thorax has been done for the chest. So this is the CT scan finding.
Who wants to take up the thing? What are the important points we are looking at here? There's RMT involvement.
Yes.
Yes.
The RMT involvement in the
in the CT. The specific points which will plan your resection.
So in this CT, I could not see any cortical bony involvement, at least in these cuts. And as far as the RMT,
The rightmost image, the leftmost image.
yeah, that shows it.
Yes, sir. Leftmost.
Yeah. Mm.
So is there
It
bone
is
erosion?
involved in the RMT and third molar reaching up to the second molar, sir.
Yeah, so we are looking at a mandibular bony involvement. So your 3D recon helps you do what? And your OPG? You want to know the extent?
Sir, it will help me see the extent of the bone involvement, so that I would like to know whether what level of the bone cut will I need for this patient. Also, I would like to get a mandibular height from it.
Okay. The patient has trismus and it's an RMT growth. What else are you looking at in the CT?
Sir, I would look at the masticator muscles involvement.
Dr. Siddharth, can you hear me?
Yes, sir.
What is this view that the CT scan is showing?
Sir, this is a puff cheek axial view of
All right.
contrast enhanced CT scan.
Good. So this patient has trismus also, is it?
Yes, sir.
Okay, so you can see that restraint of the puff cheek view as opposed to a normal person who does not have trismus. You get that?
Yes, sir.
Okay,
Yes, sir.
fair enough.
Yeah. So, considering trismus and RMT lesion, apart from bony involvement, what else are you looking at in the CT? The infratemporal fossa, right? That's
Yes,
Yes,
sir.
sir. It
okay.
is
So it's
not
not
seen
only
in
the
CT.
masticator space; it's the basically ITF involvement
Yes,
which
sir.
you're looking at. And what differentiates 4A from 4B as far as ITF goes?
Sir, 4B lesions are those in which the skull base is involved in the view of ITF.
Anything else?
How do you classify the ITF, Doc?
Sir, there are various classifications given for ITF. First is Lao et al., which divided into low and high ITF based on the sigmoid notch. Then another was in the subcompartmentalization of the ITF given by Dr. Mahajan and et al. It was divided into three: low ITF, anterior high ITF, and posterior high ITF, sir.
Okay. So, does that make sense to you?
Yes, sir. Those
Then see,
which
what
are
would be the contents of the high ITF?
so the contents of high ITF are anteriorly the retroantral fat, posteriorly as we go, where it will involve a lateral pterygoid muscle, the part of
Can you,
neurovascular bundle, the
is any of that seen in
pterygopalatine.
this current section? You're seeing a CT image here. Do you see that the corresponding section on that image?
No high ITF structures are seen, sir.
Okay, great. So what are the structures which are seen there just behind the mandible? There are some whitish dots, right? What are they?
Yes, sir.
Between the vertebra and the mandible, you're seeing
Yes, sir.
a few dots which are
The three
looking
white
very
dots.
white.
The
Three white dots.
vascularity, sir.
Which what vascular?
Sir, the internal jugular vein and external and internal carotid arteries. Sir.
Mhm. So external carotid artery will be seen here in this section.
Sir, it is seen in the last
Okay,
section, sir.
correct. That I agree, but not in the first one.
Not in the first one.
Absolutely right. Okay, and would you also look for a bony structure there?
Yes, sir. As we go down, I would look for hyoid bone.
Down. What
The lower
about
alveolar.
above?
Sir, as I go above these sections, I will look for maxilla involvement. I will also look for uh,
A
pterygoid plates,
dot-like structure like this would confuse you with what?
styloid process.
Absolutely. Yeah. Sometimes you can have a styloid process which is calcified right up to the styloid ligament. Okay. So you need to
Yes.
be aware of that when you're looking at interpreting structures here. Okay.
Yes.
All right.
So there was a 2 to 1.5 centimeter lesion in the right lower GBS with early bony erosion. There was a loss of fat plane with the adjacent base of tongue. Few prominent right submandibular lymph nodes were present, measuring about 1 centimeter. The lungs were clear. The bones were clear. So this is the CT scan finding.
Dr. Siddharth,
Yes, sir.
when they say metastasis cannot be ruled out,
Yes, sir.
what is your inference? Why are they saying that? It's their job to say it is there or not,
Yes,
isn't
sir.
it? But
Maybe
they say cannot be ruled out. So what are they trying to convey to you?
maybe that we need further imaging to look for because of the small
Okay.
size. Yes.
Okay. Then see, you want to take that question?
Sir, considering the size, also the shape of the node, if the node is, for example, round in
Then
shape, but
1
it has
centimeter.
no,
Yeah. So, what, in other words, the question you need to know is what are the overt signs where they can call it as metastasis? What are the borderline signs where they're not be able to be sure? And what are the definitive signs where they can call it as reactive or benign?
yes, sir. Sir, loss of petty hilum is one of the sure signs
In,
of
in a CT
metastasis.
scan, they will look for fatty hilum. In a contrast CT,
Is
usually that's finding in an ultrasound.
yes,
Okay. In a CT
yes.
scan, what will be the definitive sign?
Sir, round irregular lymph node. Yes, the definitive sign is extranodal invasion.
Very good. And what else? What else?
Not sure, sir.
Necrosis, central necrosis, very sure
Yes.
short sign of being a metastasis. Okay.
Yes,
So if
sir.
they had seen both of this, they're not going to give this information. But they are saying snow, which is although normal in size, just 1 centimeter and less, they are seeing that it is probably round there. It is probably having some other features which does not preclude a benign nature, nor does it confirm a malignant thing. Okay. So that is the reason why they are putting it on the borderline. Would you treat it as positive or would you treat it when you see this? Would you upstage your clinical staging or would you downstage it? Would it be N0 or would you make it N plus?
I will make it N plus.
N plus, sir.
Why? The
Sir, it is better
radiologist
to,
who's an expert is doubtful, but you're the surgeon, but why would you make it N plus?
sir, it is better to consider it N plus and treat the patient rather than land up in a scenario where
No. It is
we
going
are
by
under
the
treating the patient.
context. So now you'll have to go back to the context. I'm seeing a lesion which is eroding the bone, although it is not that big a size. And also you must go back and see what is your differentiation of that biopsy. What is the differentiation of the biopsy?
Moderately.
Moderately differentiated.
Yeah, so you know that it is not here in the buccal mucosa, you can see a lot of well differentiated. Here it is a moderately differentiated cancer, which is eroding the bone, and therefore even doubtful nodes could eventually be metastatic. So you would rather make it N plus on a clinical staging. Okay.
Yes.
All right.
So what would be your treatment and what type of, if at all you're considering surgery, what would be your
What's your surgical plan?
Sir, wide excision of the lesion along with segmental mandibulectomy and modified radical neck dissection with reconstruction.
Okay.
What will be the segment of which segment? Here you are seeing the lesion eroding the retromolar trigone.
Yes,
So
sir.
where will be your upper section of the segment?
The upper section will be transversely through the ramus of the mandible.
Transversely to the ramus of the mandible, which means you would retain the coronoid process.
Yes, sir.
Yes, sir.
Really? What use would it be to retain a coronoid process? What are the problems?
What are you leaving behind the coronoid process in this case? What are you leaving behind when you're leaving behind the coronoid?
Yes, sir. Actually, if we remove the coronoid process, it will help with trismus too. So,
Absolutely. How?
Yes, sir.
How will it help with trismus?
Sir, by disattaching the temporalis muscle.
Very good. So that is the most important muscle in the causative factor of trismus. Okay. Of course, even after detaching that temporalis, you could have a lot of fibrosis post radiation. So this guy, is this guy going to get radiation or not?
Yes, sir.
Yes, sir.
Why? How are you so sure?
So it's a T4A lesion.
T4A lesion, sir.
Yeah, and the node is also potentially positive.
Yes.
Okay, so he is going to require radiation. So radiation is going to lead to fibrosis, isn't it?
Yes.
Regardless
Yes.
of whatever reconstruction you may want to do. So what is the reconstruction will you do in this case?
So reconstruction would be free fibula
Sir.
flap reconstruction.
Okay. So what will be the technically different thing in this lesion as opposed to having cancer in the incisor or in the premolar region?
So here the fibula has to be cut and reshaped considering the angle of mandible.
Yep. So how many segments would you require?
At least
Four.
3 to 4 segments, yes.
4. My goodness, that's a lot. Okay, so you may not require 4, but we will have to discuss how much of the how will you manage the infraalveolar canal in this case? Where is going to be the other? You said it is at the sigmoid notch for one end of the segment. What is the other end of the segment going to be?
So the other end of the segment will be at the anterior to the first molar.
Anterior, why?
So considering the margin for the bony involvement, our bony involvement in the scan was up to the second molar, sir.
So you will.
Have you seen the clinical picture properly? The soft tissue, is it the bony involvement or the soft tissue involvement which will dictate your resection in this case?
So the soft tissue involvement definitely seemed to be more than the bony involvement in this case. Yes, sir.
Yeah. So it appears as if the
In between, I missed the discussion. Any one of you examine the ventral nerve? And Densi, can you tell me how you examine the ventral nerve?
Sir, by seeing the sensation over the chin region, the sensory.
Chin? What about
the
Siddharth?
chin?
I'm not sure, sir.
So you would go with the lip. Classically, the sensation of the ipsilateral lip is where you will go for looking for sensation, okay? Because that is a more sensitive region.
Okay, sir.
So if that was lost, what would you infer?
That mandibular canal involvement and neurovascular bundle involvement is more than which we could see in the CT scan.
Yeah. So where will you do the anterior cut now?
Then preoperatively, I would like to assess the neurovascular bundle involvement better through imaging.
It's already assessed. Mental nerve anesthesia is there. So what is the anterior cut now?
So it will be till the visual incisor.
Anterior or posterior to the mental foramen?
Anterior to the mental foramen.
Okay. Good. So that's the right answer. And if you did that, then you require about 2 or maybe 3 segments for the fibula. Okay. If you move more laterally, even 2 segments would do from your fibula. Okay.
Yes, sir.
All right.
What would be the prerequisite to do a free fibular flap in a posterior resection? Would you do it for all or would you do it for selected patients?
We would consider in selected patient, in patient mouth opening is adequate. And
what you should
yes, sir.
Now, suppose if you have removed both the coronoid and the condylar process, Would you still do a free fibula?
Yes, we can do.
What would
By
be the
hanging
advantage?
Did you get the question clearly, Doc? He said that if you are forced to, compelled to remove the coronoid and the,
condylar process.
yes. So condyle, if you remove, what happens?
Sir, if we remove the condyle, the muscles attached there will not work on the free fibula flap. So I will consider in this case anterolateral thigh flap would be better, because patient from the opposite side patient can do swallow chewing, sir.
You mean to say if you remove the condyle on one side, the patient will be able to masticate from the other side?
Yes, sir.
Dr. Dancy, do you agree with the Siddharth?
Not completely, sir.
So how much will you
patient-
agree with him? You remove one segment of one half of the mandible, and you see that routinely, a hemimandibulectomy done. And what is their problem in the post-op follow-up rehabilitation areas about chewing function, mastication? Do they have a problem?
Yes, sir. They have the problem in opposing of the upper and lower jaw
Absolutely.
when
Why?
ipsilateral muscles are
Why?
cut.
Exactly. Why do they have the problem with opposing?
Because the opposite muscles will contract more and will shift the mandible to the opposite side during the chewing process.
It will be pulled, drawn more medially, so the alignment will go.
Yes.
Yes, sir.
The alignment between the upper jaw and lower jaw will go. So most often,
Deviation and malocclusion will lead to the
yeah.
issue.
So they cannot
Deviation.
chew. Okay, so their food intake is going to be confined to soft solid or maximum semi-solid. All right,
Yes.
cannot be able to chew. Yeah. Okay. So the same is the case even if you do the fibula after removal of the condyle. Okay, there are ways
Yes.
in which you can do a condylar process attached to the fibula and reconstruct. But like Siddharth rightly said, if you dismantle all the soft tissue attachments there, then it is as good as not reconstructing that joint. Okay.
Yes.
All right.
Any role for neoadjuvant chemotherapy?
For this case, sir.
Yes.
This case, I would not consider for neoadjuvant chemotherapy, as I'm easily getting my margins, and resection is not very morbid. So I would go for surgery first, sir. Although if the tumor is locally advanced in the form of the peritumoral edema, if reaching up to the zygoma and lower, the edema is reaching up to hyoid bone, I would consider. And if I am not getting enough margin and my resection is very morbid, and in these cases, I will consider for NSCT.
There was a particular factor in this tumor.
Yes, sir. There is a the abutment loss of abutment with the base of tongue, sir.
Yeah.
Yes, sir.
So would you consider neoadjuvant? If you are getting good margins?
No, sir. If I'm getting good margins, I would not consider for neoadjuvant.
Dancy?
Yes, sir. I'll go ahead with surgery, not neoadjuvant chemotherapy. Considering that my post neoadjuvant chemotherapy margins will be based on my pre chemotherapy staging rather than on the post chemotherapy stage.
Oh, well,
Exactly.
if it's sure, then why have a neoadjuvant option at all? If you're
Yes,
so
sir.
sure, why have a neoadjuvant option at all? Everybody should go through a surgery because you're going to get anyway the same resection, isn't it?
Yes, sir. But those areas where they are actually functionally too morbid to consider the surgery in the first setting, then these are the situations where we can consider neoadjuvant chemotherapy.
So, for the argument you just made that you would anyway have to resect the same volume, what is the
Yes.
basis of that argument? What happens
I'm
when
not
you
able
do a
to.
neoadjuvant treatment? Dr. Siddharth,
Yes.
can you take
Uh,
that?
Yes, sir. So neoadjuvant treatment is basically given to downstage the tumor so we can
Yeah.
preserve the mandible.
No,
But sir, in this case,
no, doctor, I'm asking for the reason
yes,
why,
sir.
in spite of doing a neoadjuvant treatment, and let me argue that it has given you almost complete clinical response. Okay, there is no tumor left behind, or you are seeing less than 10% of the tumor left behind. All right.
Yes,
So
sir.
the dancer wants to remove the original volume of the tumor. Do you
Uh,
agree with that?
no, sir. I would not go pre-anesthetic margins. Although post-anesthetic, I would get as wide as possible. But I would not go for pre-anesthetic margins, sir.
All right. So you think she is speaking without some basis or rationale, is it?
Uh, yes, sir. There is a study. I'm not able to recollect at present, sir.
It's not a study. Yeah, I want you to know the mechanistic background. So, Dr. Dempsey, are you there?
Yes, sir.
So you're right, but you're right for the wrong reason. Okay. So the reason is that the tumor, when you give neoadjuvant treatment, although clinically it may appear like it is shrinking towards the middle, all right?
Yes.
So that is called the centripetal contraction of the tumor. So you may imagine it is shrinking towards the center of the tumor, but actually histologically, it is not shrinking like wholesale. It is actually shrinking, leaving behind fragmented islands of tumor tissue that is viable and lingering around in that same volume. So you are not able to define what would be the post-neoadjuvant margin that you should give. And so therefore you prefer to resect the entire volume. So used to be the case. But if the neoadjuvant treatment now involves also immunotherapy, would you guys still think of that the same way? So in other words, is there a difference in the mechanism between how immunotherapy shrinks versus the chemotherapy shrinks a tumor? Okay, all right, that's fine. I mean, we know that. That's all right.
Okay,
Go ahead. What's the next?
Next slide. Yeah.
So this patient underwent a composite resection, which included a posterior segmental mandibulectomy, neck node, selective neck node dissection, and a PMMC flap. And his tumor size was 2.1 centimeters, moderately differentiated, with the depth of invasion being around a centimeter, more than a centimeter. There was no LVI or PNI. All the margins was free. Although some amount of moderate dysplasia was noted at the posterior mucosal margin, nose were free, and bone underlying tumor, only superficial cortical erosion was noted.
So anything else you want to know about the margins, Dr. Siddharth?
Yes, sir. I would like to know for the medial margin around the BOT, which was showing on the imaging abutment, sir.
All were free.
Okay, sir.
Would you want to know the actual millimeter size? I mean, adequacy of margins, does it matter?
Yes, sir. As long as I can get more than 5 mm margins, it is adequate for me.
Okay, so you would want that information from your pathologist, right?
Yes, sir.
In addition to the histopathology report.
Yes, sir.
Yes, sir.
The PMMC good? I mean, are you happy with the PMMC, or this is a posterior segmental mandibulectomy?
Yes, sir.
Is bony reconstruction required for posterior segmental mandibulectomies? Does it really help? Or soft tissue reconstruction is good enough in most cases?
Sir, I would like to do bony reconstruction too, using plate in such a case where PMMC is planned.
Why?
Okay. Siddharth,
Sir, I would go for soft tissue reconstruction only, sir. Either PMMC or ALT free flexor.
so Dr. Dempsey, before you do your fibula, I mean, you've planned fibula for this patient, what are the things you discuss with your plastic surgeon so that there is no malocclusion even after the fibula? It does happen, Any modern technology you would use before planning the fibula with your plastic surgeon? If in case you're planning a bone reconstruction, I am happy with the PMMC for a posterior segmental mandibulectomy.
Okay, sir.
But you want to do a fibula, so anything you want to, any modern tech, any software you want to use? You want to bring a plastic surgeon out preoperatively?
Sir, the preoperatively, I would like my plastic surgeon to image the reconstruction pattern of the fibula bone itself according to the patient's bony segment, which we are planning to resect.
How? What do they use?
I'm not so sure about it, sir.
Okay, so they use CAD/CAM imaging and they design the jig according to that, so that there's an exact cutting of the fibula segments. It's all pre-planned so that there's no malocclusion even after the fibula reconstruction. Otherwise, even with a bony reconstruction, you can land up with the same problem as with a soft tissue reconstruction. For a posterior segmental mandibulectomy, a PMMC or a large thick ALT is good enough in most cases, as they have done in this case.
Okay.
Yes, sir.
So what would be the stage and the adjuvant treatment?
So it will be T4A N0. So it will be stage 4A. And the adjuvant treatment would be radiotherapy only.
Did you say that?
Yes, sir. I would also go for the same, sir.
What dose? What?
The moderate dysplasia and the posterior mucosal margin would not affect your decision, right?
No, sir.
No, sir.
Okay.
So
I think
what is the dose and fraction, doc?
Sir, it will be 55 gray, which I will give
Siddharth?
45 gray.
55 gray for high risk lesions and 45 to 50 gray for low to intermediate risk.
This patient, man. This patient, how much will you give?
I would go for 45 grays.
Why? Why 45? What will be the field you will trade for him? You know, there's a field we have to determine.
Yes, sir.
You should have an idea about these things. Okay. So normally it's a radical dose radiation. It should be 60 gray, 30 fractions with 200 centigrade per fraction. And if we want to reduce that, we need a lot of justification. And certainly 45 gray is not at all accepted.
Okay, sir.
Okay, so that's a wrong answer, 45 gray. And I would assume 55 is also a wrong answer, but there are certain situations where we may have to confront that. But the radical dose of radiation adjuvant setting is a standard thing. I don't think there should be dilemma in that.
Okay, sir.
All right? Yeah.
So, moving on to the final case, 70-year-old gentleman, multiple comorbidities, tobacco chewer, presented with ulceration of the lower lip and the left commissure since the last 2 months. So clinically, we see multiple coalescent ulceroproliferative verrucous growths noted over the lower lip, extending onto the commissure and partly into the upper lip. There's also an inhomogeneous leukoplakia which is noted in the left buccal mucosa, which is in continuity with this lesion. And the lesion also abuts the lower GBS and the gingivolabial sulci. The mouth opening is adequate, is edentulous, and there is no cervical lymphedema.
What do you think, Siddharth?
So this appears to be varicose lesion, probably proliferative varicose leukoplakia, sir, involving lower lip and going up to buccal mucosa of the left side, sir. And patient PVL, sir, with underlying malignancy can also be there. I would like to confirm with biopsy, sir.
Dr. Dempsey, I'm glad Siddharth brought this up. When there is inhomogeneous leukoplakia in continuity with a lesion like this, do you expect a verrucous carcinoma to arise from that?
Yes, sir.
So what is the malignant transformation rate in a leukoplakia when kept under observation, and what is the type of cancer you get in that?
So the malignant.
Sir,
Sorry.
Sir, in homogeneous leukoplakia, the transformation rate is around 3 to 5%, and in inhomogeneous leukoplakia, it is around 13 to 15%.
And what type of cancer do you see in them?
Sir, verrucous carcinoma.
You get verrucous carcinoma so commonly from a leukoplakic malignant transformation? What is the standard cancer you should get there?
Squamous
Cell carcinoma, right? That'll be the, what will be the proportion of squamous cell carcinoma versus verrucous carcinoma if you took 100 malignant transformations of leukoplakia?
Not sure of the answer, sir.
Siddharth, you want to take a gamble?
Not sure, but the chances of varicose carcinomas are very less, sir, in leukoplakia, sir.
Correct. So you will get more squamous cell carcinomas than the verrucous carcinoma. What is the difference? Are they the same or are they different? Is verrucous carcinoma less virulent than squamous, or is it more virulent than squamous?
Less virulent.
Less virulent. Both of you agreed on that?
Yes.
Yes, sir.
Can you tell me some examples for a cancer which is more virulent than squamous? Do you have any idea? What are the other variants of? Okay, yeah, you can say that. Yeah.
Adenosquamous variety, basaloid variety.
Correct. So, there are subtypes which could be more aggressive than the standard squamous cell carcinoma that we see. Okay. But certainly, leukoplakia leading to a verrucous carcinoma are very few in number. Okay. So, in this case, if you call this as a verrucous carcinoma with an inhomogeneous leukoplakia in continuity, I'll be very curious to figure out whether it is real or imagined. So, what will you do next?
Sir, I will do a punch biopsy from the most malignant looking area.
How do you determine that? How do you determine
irregularity, proliferative area, less of the necrotic area. And
in this case, you can see that picture. Do you see a lot of necrosis there? Where is the necrosis?
No, sir.
Then
it is more of a keratinizing areas.
Well, let's not go into that. I just want you to pick the place where you will do the biopsy in this case.
Sir, near to the commissure over the lower lip.
Lower lip or near the commissure? Would it be more on the buccal side or on the skin side?
It seems like to be done more on the buccal side.
More on the buccal side. Okay. Why would you want to use the buccal side more?
So first, the lesion there, which looks
so
like
you want to
malignancy.
keep the biopsy volume within the subsequent resection volume. You don't want to do a biopsy which will extend your resection volume, not especially when you're dealing with the lip. Okay, because in lip, we need to be very careful about how conservative we are going to be. Why do you think that?
Sir, One is cosmesis. The other is the approximation of the upper lip to the lower lip post reconstruction, so that the drooling and the complaints of
What will be the result if you end up losing a large circumference, large portion of the circumference of the orbicularis? Siddharth?
There will be loss of commissure, so there will be drooling, and also the opening of
No.
mouth
Yeah.
will be very small.
No,
sir.
doc. Here you're not going
taking
to.
the
We're
word.
not thinking of drooling. Why would you think of drooling here? See, we have to put together the orbicularis. So you may argue that we may end up with microstomia. That is agreeable.
Yes.
Microstomia. Yes.
That is the word you need to use here. We're not talking about drooling here because you're not going to leave it behind open like that.
Yes, sir.
You understand? So we're going to pull the orbicularis together and then try and get the oral continence as far as possible, even if we end up with a microstomia. So that is the issue here, isn't it?
Yes,
So
sir.
you want to keep the biopsy site so you don't worsen the situation already. Okay? All right. What do you want to do next?
I'll do imaging. I'll
Imaging.
plan for contrast enhanced MRI of face and neck region, and contrast enhanced CT scan of the thorax.
What view will you ask? For the CT, what view would you ask?
For the metastatic workup, sir,
No, no.
I did not.
Here. For this lesion.
So she said she wants to do an MRI.
Okay, so maybe we
Okay.
should wrap it up with the summarization, please.
Yeah. So just last, what is your surgical plan for this patient, and what's your reconstruction plan?
Surgical plan is wide local excision of the part of the lower lip and the upper lip, along with the commissure and the buccal mucosa lesion, with the selective lymph node dissection. And the reconstruction plan, I'll go for radial forearm reconstruction, free flap reconstruction.
Unilateral or bilateral neck dissection?
Bilateral.
Okay. Suppose your imaging raises a question that the opposite neck is negative. Is there any simple investigation you can use to elucidate the issue?
Ultrasound neck would be good enough.
Yeah. What's your reconstruction plan? If you don't want to accept a microstomia, for example, because I think 2/3 of the lower lip is going, you can, of course, join the orbicularis and get a microstomia. That's a good option. But suppose your plastic surgeon says it's not possible. So what's your reconstruction?
Radial artery.
Yes.
I will go for, sir, free flap in the form of radial artery free forearm flaps.
Anything you can use to help the oral continence implanted in the radial forearm flap.
Yes. Postauricular cartilage can be used to.
Hey. When you harvest the forearm flap, what would you add to that harvesting in this case? So in terms of oral continence, there are dynamic and adynamic ways of slinging the lip, isn't it? So that is what the examiner is asking you.
Yes, sir.
What is that? Yes, sir means?
Sir,
any muscle tendon?
Palmaris longus tendon can be implanted.
Very good. Excellent. Done well.
Okay, and Adjuvant therapy, quickly. After the histopathology.
Sir, 6 centimeter lesion. We'll plan for radiation
Yes, sir.
therapy as adjuvant therapy.
No
No nodes
way.
are there and margins 3
No
mm clearance
way.
to the
Why, doc? Why radiation for this guy?
See the histopathology report.
Why would you give radiation?
Okay, yes. Grade
What
1
else?
verrucous carcinoma. Yes.
So there is no role for radiation
No.
here. You have good margins, and then there is no role for radiation here. And even if you have compromised margins, you will go in and revise your margin and not go for radiation. This is the classical situation,
Yes, sir.
Yes.
right?
Yes.
That's why we are going on saying. So the grade 1 is also an aberration. Actually, verrucous carcinomas earlier used to be considered grade half, actually. Nevertheless, okay.
Yes, sir.
Yeah.
So yeah.
Thank you.
So I think both the examiners performed fantastically and gave very good answers. Are we done with the slides, Doctor?
Yes, sir. Yeah, done.
Yeah.
That's the last slide. Thank you.
So, thank you to all the examiners and Dr. Abhay for being such a great moderator. Thank you both the candidates. Now we will quickly
Thank you,
proceed
ma'am.
to the expert talk. I'll be sharing the slides from my end. Dr. Abhay, can you stop sharing your screen?
Yeah.
Okay, so insofar as the oral cancer is concerned, there are certain contentious issues which I thought I will highlight here. So the first issue, would you want to go into the slide mode? Yeah.
1 moment.
The first issue would be to determine the pattern of invasion. Okay, so am I getting it a little?
No. It's loading from my end.
Oh, I see. Okay.
Yeah.
I thought I'm getting a little hangover here.
Oh.
Seeing things. I think while you
Yeah.
Okay, so the first issue we want to bring about is about understanding the pattern of invasion, because not all cancers behave the same way, and we don't know why each cancer behaves in a different way. But at least there are some people who have taken the pains to study in the context of the tongue, at least, to figure out how these cancers travel different zones of the tongue. And so this is one example of a cadaveric dissection which shows you the tongue divided into three components. That is the cover, which is the mucosa and the submucosa with the superficial intrinsic muscles, and the core being the extrinsic muscles predominantly, and the stem entirely formed by the genioglossus muscle. And in the coronal section, you can actually see the septum, which is in the midline. And of course, next to the genioglossus muscle, which forms a stem, you can see what is known as a paramedian septum. Do you guys see that? Next slide. So we need to kind of interpret all kinds of our radiological examination with this cadaveric picture at the back of our mind. And this shows how a normal anatomy with of the oral cavity, so at the level of floor of mouth looks, which we already seen in the context of all these three cases. Next slide. And this is the coronal thing. And you can see exactly in the coronal image of the MRI, you see the duplication of how that cadaveric image we saw earlier. And so it is important for us to understand how the cancer is invading so we can get that definitive so-called 1 centimeter clearance all around. And in majority of the cases, you must remember that the deep margin 1 centimeter will never be the same in all the locations. Okay, next slide. So Calibres and other people who, I would consider that as desperation surgery when they try to propagate the compartmental excision for all cancers of the tongue, which I thought is a overkill. But nevertheless, their reasoning is like this as to how the tumor in the tongue can involve different components of the so-called that cover and the core and the stem. And what they here show as the tongue nodal tract is actually the area which is occupied by the neurovascular bundle, and so is potentially consisting of lymph nodes in that region, okay, which is intra tongue. Or they may actually suspect there is some tumor deposits or satellite nodules which can get stuck there. Next slide. And this is one example they want to show where that top line, which is whitish line, the median raphe, and the genioglossus muscle on the side of the median raphe, which forms the stem, showing satellite tumor invasion. Next slide. And here you see within that space, the so-called tongue node tract, the perivascular, perineural, and the muscle also containing certain tumor satellites. So this is we need to interpret this with a lot of caution because we already know that the worst pattern of invasion also is coinciding with the same thing. Next slide. So one of the usual problems when we were discussing about the preference between CT and MRI, this is one thing most people should know, that dental implants and other kind of caps would cause a lot of artifacts. But there are in good radiological centers ways to circumvent that, and they could do what is known as an angulated view and get the thing straightened. Next slide. So one is the pattern of invasion, and the next would be the depth of invasion also. And so we take a lot of pain and effort to correlate whatever we are doing by clinical examination to duplicate in the right type of radiological, and as well as duplicate that, extend that into the histopathological picture too. So here is a classical example about how this right lateral border lesion has been imaged right from clinical to radiological to the histopathological. Next slide, please. And the same case in the opposite side, the left lateral border. Next slide. So the next layer of complexity that we should understand is the tumor heterogeneity. And this is a well-studied paper which shows you that, on the top, when Dr. Dancy was talking about, digital palpation for induration around the visible ulceration, that is what she meant, that there could be submucosal extensions of the tumor of varying degrees, and the mucosa overlying that would appear almost normal or some benign looking changes in those cases. And also the thing is deeper, you can see there is a tumor which is showing various grades of tumor admixed with one another. So you can see the well and moderately differentiated tumors in green, and the purple showing the poorly differentiated cancer. So all these different types of tumor has varying compositions. So we have a problem with the pattern of invasion, we have a problem with the depth of invasion, and within that we have a problem with the tumor heterogeneity. And so therefore, a surgeon has to combat all these problems while you choose surgery as the best option for the anterior tongue or the oral cavity. Next slide. So that also brings us to the question about how we could, artifactually upstage disease or downstage disease. And these are classical scenarios where in the mandible, just because there are some odontogenic problems which can be misconstrued as disease invasion, or if there was an edentulous atrophic mandible, those things are also mimicking like invasion. So all these things, and you can note that these PET CT and other things, you do too soon after the biopsy, it is also going to make things worse for you. Okay. So overall, we need to understand that when we clinically stage with the radiological methods also, abundant caution is required before we can, boil down to a clinical stage. Next slide. So, surgeon as a prognostic marker, one singular thing we have to do is to get the three-dimensional clearance. And, the discussion whether that margin should come from the resected specimen or from the cavity is a mute question, so long as you get the clearance, so one way or the other. Next slide. So this is the classical thing. You can see that the deep margin will never be as good as the horizontal margins that we are able to visualize. And you can see the closest margin here happens to be 4.8 millimeter. Next slide. And when they slice or bread loaf the tumor, in every section, you should ensure that minimum that 5 millimeter margin is there. So there is a lot of trade-off that we need to do in so far as preserving the normal volume of the tongue, much as opposed to how much clearance and safety margin we are supposed to take. So there is error, human error always in trying to get this balance very finely tuned to the required condition and required individual. Next slide. So nowadays, the intraoperative help of ultrasound is coming up more and more, and I'm sure because this ultrasound technology is growing by leaps and bounds, soon it should be with us also, and so it will be a good idea to understand where this field is taking us right now. Next slide. So this is some of the demonstrations that, again, in a cadaveric section, they have shown. But an intraoperative thing also has been tried in centers which are practicing this. Next slide. And very much like the cadaveric dissection that the group in Calabris utilized, these people from Japan also use the cadaveric model to substantiate their claim that an ultrasound could give us an intraoperative guidance for the extent of resection we are supposed to do. Next slide. And so they are able to correlate between a clinical versus cadaveric versus an ultrasound image. Next slide. So, I mean, essentially, we should be now getting to understand about ultrasonic imaging, as this will be completely a surgeon-dependent one on the table. Next slide. And we will avoid such desperation surgeries as a compartmental excision such as this. Next slide. And the next important thing after the dealing with the primary for us would be the extranodal extension. And extranodal extension today is becoming far more important than the depth of invasion itself, because it tends to bring down your survival tremendously. And the type of extranodal extension is again classified into something which is just infiltrating the capsule or extending into the surrounding adipose tissue, or they all matting into one another, or it is clinically also extending onto some adjoining structures. Next slide. And there are definitive ways which you can eliminate the negative ENE, because a lot of mimics are around there, because there could be some inflammatory reaction that causes the same level of adherence to the adjoining structures or to the other lymph nodes as well. Next slide, please. So this is an example of the histological markers showing that the extranodal extension is getting into the surrounding adipose tissue. Next slide. So that is how a formalin fixed gross section of the node will look. And you can see in areas where the arrows are pointed out that the node is breached, and then the tissues, the tumor deposits are coming out. But we must be aware that in certain instances where we have already done a biopsy of this node, either by a fine needle or by a core needle, then you could cause an iatrogenic breach of the capsule, which should be distinguished from a natural tumor extension. Next slide. So by far, this is how the schematic way we look at the external extension in terms of pathological involvement. And the last thing that you see in E is actually soft tissue metastasis. So we, at this point in time, believe that there cannot be any kind of purely soft tissue deposit in the neck. And if you see some pathologists or anybody commenting there is a soft tissue deposit, we are expect to assume that there was a lymph node there which is completely destroyed, and then it has become a soft tissue deposit from the tumor. Okay, so there should be some underlying lymph node that should have been there in that place. Next. So today we are trying to do this type of classification, either when we use the CT, MRI, or ultrasound, about grading that from 0, 1, 2, and 3, where 0 there is no extension, and 1 is fat invasion, 2 is matting, and 3 is adjacent organ invasion. Next slide, please. So these are examples of that. Next. This is where the capsule is intact, and this is where it is extending into the adipose tissue. Next slide. And this is where it is adherent to the adjoining structures. The next one. So yeah, the same thing. Next slide again. So, in so far as the other end is where, here we are talking about node with external extension. The other end is where it's occult disease. And we have already discussed that sentinel lymph node biopsy is non-inferior. And these kind of results have been reproduced from extreme opposite corners of the world, from Japan on one end and France on the other end. And they have consistently shown that this is non-inferior. And even in our practice in our group, we can continue to do sentinel lymph node biopsy. And in lesions which are less than 2 millimeter, we don't complete the formal neck dissection also. Next slide. And of course, as against the other groups where they use both the technetium and the dye, we use dye as a lone technique. One of the reasons we shy away from using the technetium is because of the shine effect that you see. When you give the dye on the primary tumor, the submandibular glands or lymph nodes are so close to the primary tumor, there is a sun and shine effect which obliterates the pickup from the gamma camera. So I rather go more by a blue dye than technetium. Next slide. So this has been compared with elective node dissection, and then this has been proven that we could stay with the sentinel lymph node biopsy for the future, because we have follow-ups right extending up to 10 years of this data. And with us also, we have about 5 years of data to confirm on this. Next slide. Well, I don't want to spend much time, so I'm going to just gloss over these dysplasia. We saw in one of the cases there is a moderate dysplasia at the posterior resection margin, the importance of which is very, very debatable. So all the mild and the moderate dysplasias are something we can club together and keep under observation. But if it was a severe dysplasia, I would treat it as a positive margin. And this is a slide which shows varying grades of dysplasia. Next slide. And the mimics of the dysplasia is another thing we need to do, because you can have hyperplastic epithelium that your pathologist may call as dysplasia. And so there are areas of contention between clinical, your impression versus what the biopsy may eventually show. Next slide. So the same here. Next. So we would be very scrutinizing the report with a lot of lens or telescoping into it to figure out, on what basis they're calling that as a dysplastic change before we can take a clinical decision on that. Next. So the other area of the way to manage the leukoplegia, even though we had the largest screening trial in Kerala, we didn't give an answer to this question as to how a leukoplegia has to be managed. And so here we are awaiting the results of this RCT, and we will get to know whether if it is the current strategy of watchful surveillance would be good enough for leukoplegic lesion and act only when it is obvious clinical malignant transformation is taking place. Next. So a lot of the young doctors get intimidated by such changes. These are all normal changes which we need to be very clear about, so we don't overdo our diagnostic skills on these patients, because these things has to be dismissed as benign and not to be followed up too much. Next slide. The same, the host of conditions that patients may come because they are paranoid, but all the same, we should be sure that we don't add more agony to them by investigating unnecessarily. Next slide. All these cases are normal and they don't require to be investigated. Next slide. Same is the case here. So in the case of this pyogenic granuloma and these traumatic fibromas, we would make sure that we are following them up so that we don't miss out on a submucosal minor salivary gland tumor type of thing. So unlike the other conditions which are very like a clinical spotter, these may not be as obvious like we think. Next. All right, so those are the cases. Next one, please. Yep, so candidiasis, you're going to see a lots and lots, and of course in youngsters, you're going to see both zoster and herpes simplex. Next one. And these are very rare in our context. So I think I'm going to stop here. Unless there are any questions, we can answer them. Any questions?
I think you can proceed, sir,
Why?
because we're liking your presentation.
Really? All right. So anyway, I mean, there are only a couple of. So the newer things, advances that the candidates would want to know is the entry of immunotherapy, and you're seeing a lot of these studies. What was initiated as a recurrent and metastatic setting type of palliative treatment is now being advanced into neoadjuvant setting. And now, because neoadjuvant setting in certain subgroup of patients, it is giving such fantastic results. Now we are compelled to revisit that question about the original volume and whether we need to change the strategy into a risk-adapted surgery to figure out, whether if all people require same kind of approach. And one of my recent experiences just last week turns out to be in what we started as oral cancer involving the gingiva buccal mucosa with pathological fracture of the mandible and a cutaneous sinus with which she presented in a lady about in her 70s with immunotherapy and chemotherapy. She had such fantastic response. And we last week went ahead and removed a huge volume of tumor for her, only to find out there is absolutely no viable disease in that. So, this question is being raised all over the world, and whether we need to change our strategy insofar as, imagining that this kind of chemotherapy related fragmentation of tumor with the superficial healing is not the same as in immunotherapy. And these are classical trials, which are all phase 3 randomized trials, which have shown that there is also some advantages in overall survival and event-free survival. Next slide, please. Yeah, so that is the issue we were talking about. So how to manage the residual disease, or when it is a complete pathological response, what are we supposed to be doing for such patients? Next one. Yeah, so that is really it. Any questions?
Yeah, there are a few questions in the chat box. I'll just load them, sir.
Please.
Yeah. Yeah, so the first question was, what is the role of CT thorax in early CA tongue, like the 6 millimeter depth of invasion that we saw in the first case?
Yeah. So
if we have a good staging, yeah.
Yeah, for me, I would insist on a CT thorax for the following reasons. I am seeing a very poorly differentiated cancer in the primary, which is having more than 1 or 2 centimeters depth of invasion, or I'm seeing lymph nodes which are clinically metastatic, which is going down to the level 4 region. So these will be my definitive indications for a CT thorax. For that specific question about early CA tongue, I'm assuming it is T1 or T2. So there is no role for CT thorax as a standard. Maybe in a person who is a smoker, I would use that occasion as a screening tool for some lung cancer. But in the chewing tobacco, I would rather go with an endoscopy than with a CT thorax.
Right, sir. Next question is there a difference between tumor thickness and depth of invasion? And can depth of invasion be determined by MRI? Shaikat, sir, can you take that?
Shaikat is there?
Yeah, he's there. Shaikat, sir, you're mute. You need to unmute yourself, sir. Yeah.
Yeah, so there is a subtle difference between the tumor thickness and depth of invasion. The depth of invasion actually measures the microscopic depth of invasion from the, it doesn't count into, take into effect the exophytic component of the tumor. And the depth of invasion can be determined by the MRI.
Right, sir. In the first case we saw that was a fairly early tumor. Is the closure of the defect actually needed after excision?
For me?
Well, in my experience, you should always, there are people who leave it open and raw to granulate, and that does lead to a better functional outcome in case you're not putting in a free flap. It is definitely better than a primary closure, but you do run the risk of a secondary infection and secondary hemorrhage. So that is, in a real life scenario, I would prefer to close. Whether transversely or longitudinally depends on the nature of the defect. Sometimes you can do a V-shaped excision, and the base is also taken care of by the apex of the V, and that leads to a very good functional outcome even in case of primary closure.
Okay, and in case if you're closing the defect, is it closed transversely or longitudinally?
Yeah, so what do people normally tend to do is turn it around.
Yeah, turn it around.
And suture. That is good if the lesion is posteriorly placed. Anteriorly placed lesions do cause speech defects if you do that. Longitudinal closure, the thing does lead to a serpent tongue sometimes. So it actually depends on the kind of defect you land up with and the location of the defect in relation to the how anterior or posterior it is. And you have to really individualize the closure. I personally favor a V-shaped excision and a transverse closure in cases I do primary closure, but I tend to put in air on the margin of free flaps more and tend to do less and less of primary closures nowadays.
Right, sir. Mani, sir, do you do anything differently, or do you also
See, for a case specifically asked in case number 1, Sometimes I would discourage from a free flap simply because if you it's the smallest free flap you can do still will be like a big load on the tongue. So they will be like talking with a hot potato in the mouth sort of thing. So closure, primary closure is not a bad idea, and we ensure that the transverse closure is just sufficient so as not to cause a big raw area. So we do a kind of bridged version, partial closure primarily, and the areas where it does not fall in line correctly, we leave it as raw area. So you could do a blend of both.
Okay. Coming back to the imaging, if it's an advanced tumor and you want to image the ITF, is CECT enough to identify perineural spread, or do we also need an MRI? Mani sir, can you take that?
Yeah, I would do both. Because when we are talking about perineural disease and we are talking about perineural disease in the context of a squamous cell carcinoma, that means already it is predetermined that it's a bulky tumor, and we are looking at borderline resectability issue. So if you at the outset identify there is perineural invasion at the skull base or beyond, then it will preclude any kind of future resections as well. So I would invest in doing both MRI and the CT scan to identify the perineural disease. And here we are talking about the nerve, which is the mandibular nerve or the foramen ovale and the foramen spinosum region. So MRI is going to help us with determining the thickening of the nerve as well as the loss of the perineural fat tissue that will get distorted when there is perineural disease. So that is what the MRI is going to help me do this. And I can also trace this MRI intracranially and look for certain deposits in the cavernous fossa as well. So I will be keen to use MRI on this context. But there are instances where you can indirectly, as a surrogate for perineural disease, see the enlargement of the skull base foramina. And that is well picked up by a CT scan. So I would use both. And I would use both because in a case of borderline resectability, the neoadjuvant treatment brings us an exceptional responder. Then we should not have any kind of dilemma whether to convert that into a curable disease and go for a resection or not after that. Okay, so we need to preoperatively have a classical documentation of all this.
Right, sir. And that will be a contrast enhanced MRI.
Absolutely, yeah.
Right, sir. So now, Dr. Abhay, can you take the last question? Will your margins change after NACT in oral cavity cancer? I think we've partially discussed this during the examination session, but just to summarize.
So we retain the pre-chemo margin. So what was the size of the tumor pre-chemotherapy? The same surgical defect needs to be incorporated to achieve, because as discussed, the shrinkage of the tumor is more like a sandwich pattern rather than a concentrical pattern. So I would go for the pre-chemo imaging and determine my surgical plan. But if you're using immunotherapy, then it is very difficult to substantiate a very large resection and then ultimately say that you do not have residual disease. So that in those cohort of patients, you need to be a little careful. But standard chemotherapy, I would go for the pre-chemo.
Okay. But frankly, how many patients in your OP are getting neoadjuvant immunotherapy, sir?
No, none at this point, not that many patients.
At this point of
But
time.
it's coming up because of the low dose paper which has come out. Many people are being offered the low dose immuno as well.
Okay. Okay. So I think we'll wrap up this session. Just a gentle reminder for anyone who has not yet registered for NatCon 2026 to be held in Lucknow on the dates 9 to 11th of October. The registration is still open. Our next session will be chapter 11 of Mastery of Surgery, where we will be demonstrating surgical anatomy and videos, operative videos on oral cancer, which will be on the 28th of April. Following which, in the month of May, we will be doing Masterclass, chapter 73 on pancreatic cancer. Now, I invite our IASO President, Dr. T.S. Rao sir, to wrap this session with the vote of thanks.
It was, I think, one of the longest sessions ever. It never went beyond 9 o'clock. It actually never went beyond. It was full 2 hours only because it was very absorbing. And rarely do I sit through any session. There is a usually going on. That is one reason, but I was sitting here. So it was wonderful. And the students were excellent. Both Siddharth and Densi did a good job. Mani, Shaikat, Abhay are seasoned campaigners already. So they were expected to do well, so they did well. Brilliant. Good moderation, excellent examination by Shaikat, very good moderation by Abhay, and then the expert talk was excellent. I think this session will be watched by many people on the YouTube. Okay. So, on that note, I think thank you very much for your active participation in IASO, and please attend NatCon. Sanjeev Mishra, Arun Chaturvedi, Vivek, and all of them are doing a great job. Samir, all of them are working very hard. Register for the event and make IASO strong. Thank you very much. Good night.
Thank you.
Thank you, sir. Good night.
Thank you.